I just wanted to do something right before we went on, just to be risky.
Shell game?
Shell game. Okay.
Which one? Hey, you're really good at this for your first time.
I think they all have something in them, though.
They might.
I don't get the point of our game.
There is no point. That's the point.
Thank you for joining us today on Facebook Live. I'm your host, Melanie Jones, and our guest today is Dr. John Flucke, a practicing dentist from Kansas City, and also the technology editor for Dental Products Report. Thank you for being here.
Thank you for being here and for allowing me to kind of demonstrate my quick little shell game for you.
You could probably make some money somewhere.
Not
here. I don't have cash. Sorry. Today, we're going to talk to Dr. Flucke about an article he published with a very provocative title. Why don't more people care about this type of technology? Spoiler alert, we're talking about curing lights.
We are. And it's because I think for most of us in dentistry, when we come into the room and we sit down and we prep, we do all the things, and we're very conscious of things, like moisture control and the proper emergence angles and bevels and all those sort of things and shades. But when we get in the heat of battle and we grab the light and we hit the button, as long as the light comes out blue, hey, we're good. The only problem with curing is when you hit the button and nothing happens, which is, usually a bad day. But we don't really think about what the curing light is doing or how it's doing what it's doing. And so because of that, a lot of times I think that the curing piece of what we do is probably the least looked at after and the least respected.
So let's get an education today about the physics of curing lights. Let's talk about, first of all, photoinitiators.
Okay, fair enough. The thing about curing lights is I tell people all the time that curing lights to me are like the stepchild of adhesive dentistry because they're always around, but nobody really pays attention to them.
Hey, my stepmom loves me.
I had a terrible childhood, which we won't go into here, but maybe another time. But the physics of the different photoinitiators is such that what you want to do when you cure is the light is very, very intrinsic, obviously, to a curing situation unless you're using some type of a self-polymerizing composite. And so when you're working, you want to make sure that the light is as close as humanly possible to your target area. If you don't do that, then what you end up with is, I've been in offices before where you'll see people put the curing light down, put it on the composite or near the tooth, and then they'll turn away because they don't want to, damage their eyes with the light. But when they turn, they'll tend to flex, this way, and the hand travels as well. And because of that, you won't get as much light on the target as you need. And even a distance of a couple of millimeters can make a really big difference in how much light is actually put into that tooth. And that directly leads to lots of different problems that can show up in curing if you're not right where you need to be all the time.
Yeah, it's true. And our camera pulled away from you when you showed how you shine and then turn away. And the light kind of migrates. Yeah,
so it's kind of like when you're driving and you look over your shoulder and eventually you'll catch yourself. I've kind of pulled, a little bit to the right or a little bit to the left, depending on which way you're looking. And, so obviously the smartest thing to do would be get the light right there and watch it, which is one of the great reasons that you need to have some type of a filter. But for a lot of people, they either don't use a filter or the filter isn't in quite the right place. And so they end up, I've seen people close their eyes. I've seen people look away. And obviously, anytime you're not looking at where you're supposed to be aiming, things can go awry.
Right. So let's talk about some of the problems that are caused by an insufficient cure. Excuse me.
That's easy for you to say.
Is it?
Yeah, well, okay, when you're dealing with composite, is that, it's very easy with a light as intense as the Velo. It's probably a matter of, you could be maybe within 10 millimeters of a composite, and you're going to get what seems to be a decent cure. But the problem is, with that light being so far away, you may get a great, photoinitiation of the occlusal layer, maybe, 1 or 2 millimeters deep. but it's not going to go where you necessarily always want it to go and cure everything. And because of that, then you end up with what I call candy composites, which are composites that are crunchy on the outside and chewy on the inside.
And now you've made me hungry again.
I think we've got a Snickers around here somewhere for later. But what happens with that is, because of the lack of depth of cure, what happens is you lay your layers down, and if you're looking away and not getting the light where it needs to go as you're putting those layers down, you will end up with something that seems set, but then underneath, along the pulpal floor, you're getting some give. And when you load that occlusally, you're going to get some give of that composite. And what's going to happen with that is that's going to cause flexing of the material. The flexing of the material is going to create a pressure differential across the dentinal tubules. And then you're going to get the situation that we've all had to deal with, where the patient comes in and says, every time I bite on this tooth, it hurts. And so you take a look at the tooth and you check the occlusion. The occlusion's perfect, but yet if you get a tooth sleuth or something else that'll allow you to isolate just certain parts of the tooth, you'll notice that every time you get on the central pit and they bite down, they load that occlusally, yeah, that's what hurts. And that's because of improper curing. And the other thing is, when you've got improper curing like that and you're getting flexure, then you run the risk of getting marginal breakdown, because microscopically, as that set composite along the occlusal flexes because it's not set underneath, then you start to get chipping at the margins. Gaps come open that they look like the Holland Tunnel to bacteria. They get in, you get recurrent decay, or at least ditched out margins that are food traps and other things. Just leads to more problems about the long-term reliability of your restorations.
So seriously, why is this type of dental technology so underappreciated?
I think it's because people just don't quite understand all the stuff that goes into it. I've heard of people buying curing lights, from overseas areas. I paid $100 for my curing light, and I say, well, really, how intense is it? Well, I don't know. Well, what wavelength is it? Well, I don't know. Well, if you don't know, what color the blue LED is putting out, and you don't know the intensity of that beam, how in the world can you say, well, I know my composite's set? I mean, I wouldn't let anybody put that in my mouth. There's just too many variables to go crazy. And somebody's got to be the Pied Piper, I guess, for this. And I guess right now it's me.
It's you. Dr. Fisher always says there are two pieces that are really important in adhesive dentistry, and there are a lot of other things that techniques can vary and products can vary, but two things: your curing light and your adhesive.
Yeah.
Do you agree?
Oh, absolutely. Yeah, absolutely. If that adhesive is not everywhere that it needs to go and set properly, and if that adhesive, is not then, the right one to, to bond to the composite, that's a problem. And once again, the light, if the light isn't bright enough, if the light for some reason doesn't reach the target, there's lots of things that can go haywire with that.
If the light doesn't photo initiate.
Bingo. Yeah.
Also, the photo initiator that's in that specific composite.
Yeah, and most composites nowadays do have the same photo initiator. Across the board, most composites, I emphasize the word most, are using camphorquinone, or you'll see it in the literature sometimes as CPQ. And camphorquinone is a material that starts the whole chemical reaction that causes the composites to set. And camphorquinone is activated at around 465 nanometers, which is in that blue range. And most curing lights on the market put out 450 to 470 nanometers of light. And so what that allows you to do is it allows you to get in that butter zone of exactly where you want to be to cure a composite. And as you're curing a composite, then camphorquinone also does vary a little bit. It will also polymerize a little, maybe 10 nanometers or so on either side of 465. So a light that puts out 450 to 470 is going to be adequate for those types of restorations. But there are proprietary photo initiators out there. And for variable reasons, some companies make them and they do change from time to time. But what you really need to ensure that you set everything is a broadband light, which the Velo happens to be. And the broadband aspect of this is that the Velo has 4 LEDs built into it, and 2 of them are at 465, and then 2 of them are lower in along that scale, and that allows the Velo to then set everything that's on the market. So no matter what material you happen to be using, no matter what photo initiator happens to be in the mix of that material, you always get it cured with this. And I'm going to show you here on this little fluorescent piece. As I hit the button, what you're going to see is you're going to see 4 little different spots. One of them is kind of a reddish pinkish, and that's actually the one that's the lowest. That's 405 nanometers. And this is what allows the Velo to set everything on the market, is that you've got all these different wavelengths put into this one device. And that also means that it's a little like the old laundry detergent thing, one light, all materials. You pick this up and you know it's going to set whatever you happen to be using at that moment. There's no reason to think, oh my gosh, is this something with proprietary? Oh, I'm trying a new material. What's the photo initiator? With something that's a broadband, you don't have to worry about that.
And in the past, dentists didn't really have to worry about this because everyone was using a halogen light.
Right.
And halogens already cured everything because the spectrum was so broad, but they got hot because of that.
Very hot.
Required a fan, heavier.
Yep. Cords. If I had a nickel for every time that somebody had turned in my office and drug, the control part of the halogen light onto the floor and had it hit.
Yeah, smash the light guide.
Exactly.
Yeah.
And so, and they were bulky, they were hot, and, they did cure everything, but, we're at a point now where everything's evolved past that. I mean, everybody is doing LED now, and the important thing to remember about the LEDs is simply intensity. And then what are the wavelengths? Is it a single wavelength? Are there, 3 or 4 LEDs in there? They're all 450 to 470, or is it something like the Velo that will set everything on the market?
Now, Dr. Rafiq Hakim has a question for us. When we were talking about adhesives, he says,
Sure.
How thick should be the adhesive to give it maximum strength?
Well, what I like to see when you place an adhesive is you're going to go in and you're going to etch. And this is talking about 5th generation, by the way, because I'm a 5th generation guy of total etch. And then I go in with
PQ1
Yeah,
guy.
exactly. Yeah, I am. And so I go in total etch, and then you apply your bonding agent. And so I'll scrub that in really well. And then you want to get an airstream on there from about 10 millimeters away. And that is because there is a solvent in there, ethanol, that's a solvent in most of your bonding agents. And you want to evaporate that. And so you want to evaporate that, thin the bonding material or the bonding agent out as much as possible. So I don't really like to have any kind of a puddled surface. If you look in there and you see any surfaces that look a little milky, it's probably too thick in there. What you want is moist dentin, but you don't want any real big puddles. And you want to make sure, and one of the reasons that I'm a big one on working under magnification as well, is you want to make sure that all the areas that you need covered with adhesive are covered, but it ought to be really, really thin. As thin as you can probably get it would be best.
And no dry spots, glossy.
Correct. Yeah,
surface.
Glossy but not milky is
Not
probably
milky.
the best way to put it. Because the other part about that, is on that surface, what you're trying to do is to get the collagen fibrils to bond into this. And the collagen fibrils, if you think about spaghetti, or like a sea anemone. A sea anemone, when it's in the water, those tentacles come up and they're all like this, but if you take it out of water, they just collapse. It's the same way with collagen fibrils, which is down in the tooth along the cut surface. And so when you get the bonding agent in there, if it's thin, you get those fibrils standing up. But if you over dry it, then they collapse and you don't get nearly as good a bond. What you want is things to interlock so that you get a really good bonded surface.
Dr. Hakim says thank you.
Oh,
and
hey,
thank
you're welcome.
you.
Thank you
for joining us. Anybody else who has questions, please feel free to type them in. We'll continue to answer.
Because otherwise it's just she and me.
We're pretty entertaining, though, I think.
Well, I'm entertaining living daylights out of myself. So.
Yeah, we can only say that about ourselves. Talking about curing composite, there are a few things I want to mention. Sometimes people have trouble with composite getting cured to the lens.
Yep.
How does that affect bonding, and how can they prevent it?
Okay. I practice in the Midwest, and so the analogy that I like to use for that is simply your windshield in the summertime. If you drive at night, where I'm from in the summertime, you will hit bugs galore. And before long, you're looking between the bug splatters to try and figure out where you're going. And it's a similar situation with a curing light. If you don't somehow shield your curing lights with either saran wrap or an intraoral camera sleeve or a sleeve that the manufacturer makes for the device, If you get in on the tooth and maybe the assistant has aired it, and so when that happens, oftentimes a bonding agent will kind of get pushed up and maybe come down on another tooth or something. If they come down here and come on it, and there's uncured resin on the tooth, and then they activate the light, what happens is when they take the light away, that resin is now stuck on the lens. And over time, you've done that a few times, you start to get, whether it's composite or bonding agent or whatever it is built up on there, and the light begins to lose intensity and efficiency.
It's going through a film.
Exactly, yeah. So you can have, a very, very bright light, but if the light can't get out of the light, if I put my hand over a tooth and tried to cure it, I have the light on right now, but you can't see it because my hand is in the way. It's the exact same theory, is that when you have a lot of debris built up on that lens, then you just have problems. And the easiest way to prevent those problems is just to not have them in the first place, which is why I'm such a big advocate of sleeving. A lot of people tend to think that the sleeve is just for infection control, which it is. It's a good way to do that. Barriers work. But for me, even more important than the infection control piece of it is the fact that I don't end up with all kinds of gunk stuck on the end of my lens that I've got to then try and figure out how to get off without damaging the lens. Because if you scrape it off and you gouge the lens, now you've got the light, instead of coming straight out, the light's getting, going through different, areas and different prism effects, and it decreases the efficiency.
I'm so glad that you brought up collimation just now.
It's funny how that works.
It is. I think we should show the collimation of the Velo.
Okay. One of the really cool things about the Velo that you just don't see on other curing lights is the Velo actually has a convex lens that goes over the diodes here where the LEDs are, and that lens focuses the energy. So, earlier I was talking about curing or restoration, and, if you've got it sleeved, you can actually make contact with the tooth if you want to, and you're not going to get the debris stuck on here. Well, that's really well and good to be as close as possible, but then sometimes people will say, well, that's fine, but then what do you do, if you're curing and you're going into a proximal box? A proximal box can be 6 or 7 millimeters away from the light, even if the light is directly on top of the tooth. So what do you do? And in most instances, there's not much you can do. You cure it, 2 or 3 times this way, and then when we take the hardware off and we remove the matrix bands, then you'll want to come in and cure, buccal and lingual and from wherever else, you've got composite. But one of the nice things that the Velo does is the Velo, and I'm going to use a little bottle full of some food coloring here to show you, that convex lens on the Velo actually helps focus the photons that are coming out of here. So the energy from the light, right there, you can see it passing through that bottle. That lens focuses that light better so that it will go down into deeper areas and give you a better cure. So, if the proximal box, if the floor of that is, 6 or 7 millimeters down from, where the light happens to be resting, you aren't going to get as much energy delivered down there, 6 or 7 millimeters, as you would if this were, right on top of the restoration. But it does provide a lot more energy down into there for you to know that you're getting a really good jump start on the photo initiating, so that when you're done and you take, all the hardware off and then begin your multiple cures from multiple directions, when you're doing all of that, then you know that you've already given the restoration a good start before you actually go to those other ways of curing.
Now, you talked about curing from all the angles of the tooth. In your article, you mentioned something about the tooth turning into a heat sink.
And that can happen. We talked about the heat that comes from the halogen lights, and they did get hotter than LEDs. But if you put an LED light on your finger, hit the button, and hold it a while, you will start to notice that your finger does heat up. And because of that, most of us, we all know we can't over-cure a composite. So most of us will then go in and we will cure from multiple angles at multiple different, sides and everything to make sure we've cured. And usually what we're doing is we're then curing from, maybe we're coming in from the mesiolingual and we'll cure there maybe, 2 or 3 times to make sure. And then we'll come around to the mesiobuccal and we'll cure 2 or 3 times there. But each time you hit the button, suddenly that, the heat that's coming out of this starts to take effect on the tooth, and the tooth begins to retain a little of that heat over, the multiple cures. And what happens with that is you can actually overheat the tooth, accidentally by trying to do good dentistry. And so what you want to do in those cases is either, in between cure cycles, stop for a couple of seconds and let that heat dissipate, or simply blow some air across the tooth with the air water while you're doing the curing. But you want to remember that, about 5 degrees C is enough to cause, some type of pulpal flare-up. It's usually reversible, but that's enough to actually cause some pulpal trauma, and that can lead to, of course, post-op pain, post-op sensitivity, other things like that. And once again, now, you're playing that game of, is it the restoration? Is it curing? Did I accidentally overheat the tooth? There's a lot of things you've got to start running through when people have, sensitivity. And obviously, if you can eliminate as many of those as possible, it's best for everybody.
Curing light's one thing we know we can.
Exactly. Yeah, you can absolutely.
You can control that.
Yeah, you can. And it's simply, a lot of devices will just kind of keep on and on and on as well. And that's something, if you're pulling the trigger or pushing the button every time the thing goes dark, you're just generating a lot more heat than that tooth really needs.
Mm-hmm. We have another question. This is from Mohammed Al-Saidi. If there is a gap between the composite and the prepared tooth were to happen after filling completed, what can I do at this time?
If you've got a gap between the restorative material and the pulpal floor, really the only way you're going to be able to fix that is to go back in and replace the restoration. Now, the real problem with that is being able to accurately diagnose, is that the problem to start with? And that's a tough call. Because, if the composite isn't properly cured, when you bite, the squishy composite is going to give a little bit. You're going to get that differential of pressure across the dental tubules. But if this is the composite, or I'm sorry, this is the tooth and this is the composite, if you have an air bubble, now when they bite, the air bubble is going to flex a little bit. The composite's going to flex and drive the air into the dental tubules. You're going to get the exact same effect. So it's really kind of hard to be able to look at that and go, oh, that's obviously, there's a gap in there. Mm-hmm. It could be a lot of different things that are causing it. So in that case, if it's really severe, I would just go ahead and just plan on doing a new restoration. Mm-hmm.
We have another question. Dr. Rafiq Hakim, he's in Toronto, by the way. Thank you for tuning in. How about the tips that can be bought with the Velo? How effective are they, and in which situations?
Okay, well, there's a lot of different tips that are available for the Velo, and they're actually pretty neat. This is what we were playing the shell game with earlier. And for instance,
I think we're going to find out there's something in all of them.
There really are. Yeah, there really is something in all of them. The one I'll show you first is the point cure lens. And with this point cure lens, it has a very small diameter tip, which I think is about 2 millimeters. And, a lot of us in the old days of the gun-style curing lights, we would actually have a removable light guide that then you could take and put another light guide on that had like a 2 or 3 millimeter spot tip. This one, the nice thing about the Velo is that these are magnetic, and there's a little area of metal here around the light, and those simply pop on there with the magnets. And so now, because they're black, it removes most of the light. And so if you're going to do something, like a veneer, and you want to tack cure it so that you've got the veneer set, but then you can remove the
clean up
around the margins, then you've got just this one little dot that's going to cure and not the whole surface. And so, great thing for that. We also have, I'll put this one back in here. We also have the transillumination lens, which...
Here, I'll help you.
Thank you. Transillumination is a really big deal. I love being able to look at things from a variety of directions. And so they make these transillumination lenses that you can pop on and then simply put interproximally on the teeth and come at it from, like that, or I can kind of show you here from the buckle, because you can use it either way. But this is an amber color, and what that amber color does is it does let you go in there, and then you can see, the interproximal areas, and if there's anything dark in there, then you can tell that's carious. I don't exclusively diagnose using just transillumination, but on those
Right.
spots where I see something and I think, could that be curious? And one of the things I want to say is I'm working under 5x magnification, and I'm also working under a light that's about 7,000 foot candle. So I'm working under a really bright light, off of my glasses. So oftentimes my light is transilluminating enough in those areas that I can see things that I then need to validate. So if I see something, I think I've got to have validation on this because it certainly looks suspicious. Then I grab one of the transillumination lenses, put it on there, turn my light off, look back at it with 5x again, and run it across, and I can either see or I won't see, what the problem is.
When would you use the green versus the amber?
It kind of depends. Tooth color for me more than anything else, really. Shading sometimes, if you've got folks that have kind of a darkish, more brownish or orangish color to their teeth, it'll absorb more of that orange, so the green works better in those cases.
Okay.
We've got the proximal lens, which simply allows you to go down into the proximal box and you can push the matrix band against the adjacent tooth and cure.
Now, how do you keep that from getting composite stuck to it?
That you don't. That I try as best I can to put a little piece of saran wrap over or something. That's the best I've found for it. That, or if you can, get that on there ahead of time and then sleeve it ahead of time, then you don't have to worry about that as much either. And then we've got the EndoGuide lens, which I'm not really going to take out of the box, but it's something that allows you to look down into the tooth and look around for cracks and such. And then the black light, which turns this into a fluorescent area. And this lets you go in and check the margins of your sealants, margins of your restorations, and carries actually under 405 nanometer light, which is what now is coming out of there with that fluorescence, I believe. That will actually glow, and you can see defects and such and check the marginal integrity of things. Something else that I would want to talk about with the Velo is the Velo is incredibly durable. And this has been one of the big things that I think has really, in addition to the power and the broadband, has really set this thing apart. It is milled. You think that CAD/CAM in dentistry is expensive and impressive. It is CAD/CAM milled out of a cylinder of aluminum. So this is actually aerospace grade aluminum, and there's several different grades of aluminum, but there's aerocraft grade, which is strong enough to use in airplanes and aircraft. And the aerospace grade, they actually make satellites and missiles out of this. So the Velo is made out of the same stuff, but they put this bar in a CAD/CAM machine at Ultradent, and it literally machines out, this. And then they put all the electronics in it. Now, because of that, the strength that's imparted to the device, being that it's made out of aluminum, is in dentistry, everything hits the floor eventually. I've dropped more stuff than I care to think about. But with this, if you're picking it up or your assistant goes to reach for it and something like that happens, most lights are going to break because most lights are simply plastic. But this, comes right back for more. I would tell you that if you have a curing light right now in your office that isn't a Velo, do this.
You keep scaring me.
I'm probably going to pay for the
can
dent
survive.
I just put in the table, but there you go. Be glad the table has a drape on it, or be throwing it on the floor.
Yeah, that's true. Speaking of which, that bar, I'm surprised you made it through security with that, considering your last story.
Yeah, true story. I was coming through Minneapolis a while back, and I had this in my computer bag. And it was on a Friday night, and amazingly enough, I was the only person going through security at that particular moment in time. I don't know how that ever happens in a major airport. But I went through, and they ran my bag, and I saw them stop, and whose bag is this? And I'm like, I'm the only guy here. It's my bag. So they said, we got to look in it. I said, okay. And they reached in, and the guy pulls this out of my laptop bag, and he looks at me, and he goes, what is this? And I said, well, it's aerospace grade aluminum, and it's really strong, and I consult with a company that makes things out of this, and so I've got this here to show people and show them the strength and the durability and blah blah blah. And the guy just kind of looks at me, and he turns to the supervisor who's kind of sitting in a crow's nest position in an elevated chair, and he goes, Bob, he's trying to take this through. And I thought, this is it. I'm going to jail.
Because there's nobody there, right?
There's nobody there. They have nothing to do. I mean, why not make a quota on body cavity searches on me because they've got the time? And so Bob says, "What is it?" And the guy looks at me and I said, "It's aerospace grade aluminum." And Bob goes, "Let it go." So I got on the plane with it. But that was the last time. I have not flown with one of these since.
Now we ship it to you, to your lectures,
yeah,
right?
now when I want to show that, they ship it to me. The other thing about the Velos I want to talk quickly about is the fact that their batteries are not proprietary, so you can get these batteries at other stores. I mean, you can obviously get them from Ultradent if you want to.
And they come with batteries
Yeah,
to begin with.
they come with 4, so I've got one over here or 2 over here in the charger. They come with a charger, so you've always got a set in the device and a set charging, and they charge in, I think, a couple of hours, so that's not a big deal. There are now available different types of the cordless Velos. There's the original Velo cordless, and then there's the Velo Grand, which has a 12 millimeter curing lens on it. So that one's a little bit bigger, covers the entire occlusal surface of a molar, which is really nice. And it also has an on-off button on the bottom now, so if you hit that, it's going to come on. I don't want to do that and ruin the camera. But so you have a couple of choices now in Velos, whether it be the Velo Standard or the Velo Grand. Other than that, the power output is the same, the weight's about the same, the durability is the same. The main differences are the power button and then that curing lens that still gets the convex and still delivers the energy where you want it, but it does it on a 12 millimeter.
You should show them the power button, by the way. This was, I believe, suggested by a customer. Is that right, Mike?
I think it was.
Mike is in the back. You can't see him. He's lovely on set, but he says yes, that was suggested by a customer so that you could hit the button from underneath.
And that's one of those things where when I got the Grand, I hadn't really noticed, because I don't do a lot of my own curing. Most of the curing in my office is done with my assistants. But I'd never really noticed how they had to kind of sometimes fudge getting the light where they wanted it and still get their finger on the power button. Well, now, no matter what direction, it's really great on the maxillary, because when the light is going up, you've now got the button right there, where before they had to kind of twist and go like that. And once again, you're twisting your wrist and you're trying to stay with the tooth and the restoration. So that can cause problems. So that just makes it a whole lot easier. And it's a great it's one of those things where it doesn't seem like a big deal until you're using it intraorally, then it's a big deal.
It's like not having enough cup holders in your car.
Bingo.
Right.
Bingo.
Dr. Hakim, first of all, informs me he's from Montreal, not Toronto. I'm sorry, my memory is failing me. Bonjour. And I think that answered his question. He asked if you found a difference between the Velo and the Velo Grand, but if you have additional questions about the difference that he didn't cover, go ahead and type that in. We have a question from Hind AT. In case of minimally invasive endodontics in which there is limited access opening, what about the bottom layer of composite? Is it going to be affected? And in case of class 2, what about using contact point instrument in the box?
Oh, you certainly can. The contact point instrument is great in the proximal box. As far as minimally invasive endodontics and keeping the small access, what I would probably do in a case like that is I might actually use the point cure lens to focus things down in there. Depending on how big your access point is, this is I didn't get the endodontic lens out before, but now we have a reason to. So there it is. And that one could also, deliver a lot of energy deep down into the tooth. So if you've got a material that you're trying to cure and you're afraid of maybe not getting enough energy down in there, then that might be a good solution for that as well. There's always also auto-polymerizing resins if you're really concerned about that and you want to cover it over. So.
You do it for just a super adaptive layer and then fill with paste type?
Yep.
Yep.
Absolutely.
Another question from Adalberto Vasconcelos. Great discussion on this topic. Dr. Flucke, let me ask you a question. What is your opinion about potential issue regarding polymerization shrinkage stresses due to start curing composites with such a higher irradiance?
A couple things on that. I'm not a big fan of bulk cure. Bulk cure to me, it's a little dicey as far as sometimes it seems to work, sometimes it doesn't, but the biggest problem that we seem to be having nowadays with that is when they measure polymerization shrinkage, pulling the cusps together, is still there. And so because of that, I'm a huge fan of incremental placement, 2 to 3 millimeters depending. You know, sometimes 2 on a darker composite, because the darker composite, the light doesn't penetrate as well. So in the D shades, maybe I go, you know, a thinner layer. And with like an A2, A3, I'd probably go with a 3 millimeter layer. And that's important because you want to make sure, once again, that you're getting the curing all the way through. And there was another portion of that. Well, can you read that back to me again one more time? Because I know I answered part of it.
Shrinkage stresses due to starting curing composites with such a higher irradiance.
Okay. Yeah. The other thing is that this device has a lot, I shouldn't say a lot, but it's got 3 different power levels in it. So it's got a super fast, which is around, I want to say 3,700 milliwatts per square centimeter. And then it has a longer medium range and then an even longer low range. So that allows you to control the amount of energy that you put out. So you're not going to, you know, necessarily take the Velo and every time you hit it with a composite, are you going to put it out with such a high energy like 3,500 milliwatts per square centimeter? You're going to, depending on what you want to do and depending on where you are in the belief system of composite shrinkage and rapid cure versus, you know, slower cures, you have those options with the device of being able to take it, you know, as for a longer cure at lower power. So it's a great light and it has a lot of output, but you're not forced to simply use the same output every time. I guess that's probably the easiest way and most concise way to say it.
Thank you. Next question from Dr. Mohammed Khalil. I believe, now I am uncertain of my record, but I believe Dr. Khalil is from Baghdad, if I remember properly.
That is cool.
He joins us for many of these Facebook Live broadcasts, so we're always happy to have you with us, Dr. Khalil. He says, about curing time, 10 seconds or 3 second shot, what's parameters to choose the time and the mode?
I like the 10-second better. The 3-second, once again, you know, a lot of the polymerization shrinkage that we see comes out of the faster cures. Now, is that always detrimental? Not always, but could it be? Yeah, it definitely could be. And I think the science just isn't there yet on everything rapid cure. And so I feel better personally with a 10-second cure than I do with the really high 3-second cures. Now, if I was going to do something like, you know, if I was going to bond on ortho brackets or something, a 3-second cure is probably fine, you know, because that's, you're going to set it, you've got metal in the way and other things to go with it, but on a normal everyday bread and butter dentistry that I'm doing, I use the 10-second mode.
10-second. One thing I don't think we've covered, you talked in your article a lot about the low profile design of the Velo. Can you show us on the typodont?
Sure, absolutely. So this is kind of funny because what's really important is getting, as I've said many times, getting as close as possible. I grew up with the trigger gun styles of curing lights. And that's the only thing that was around for quite a while. And so when I call this a toothbrush profile as opposed to the gun profile. Because I think it looks like a powered toothbrush. Yeah.
Right.
So I was a gun guy, and I was like, I don't know about these. And then what I thought of one day was I was using a gun style with a light guide that comes out and then comes at like an angle. Yeah. And I was having to practically do what I call lion tamer dentistry, which is where you grab the patient's upper and lower jaw and stick your head in. And the poor patient, trying to accommodate having that angled light guide on a first or second molar was very difficult on this person. And I realized that, hey, wait a minute, much lower profile to do this than to have this light guide, be up at an angle like that where you force the patient open more. Usually with the Velo, you can usually have the patient open around 11, 12 degrees, and it's more than enough to compensate for that. But those light guides do force people to open further. The other thing that's nice about the low profile design is when you are curing, whether it be on the lingual or you're coming down the buccal corridor, either side, once again, it's just a lot easier to place. I mean, when you think about it, there's a reason why toothbrushes don't look like those light guides, because you'd be, brushing like this, and that's, counterintuitive to what you want to do. Why we didn't think about this 20 years ago, I have no clue. But it's a great design. We never made a light that did that, so. Well,
I don't know.
That's true. And I'm stubborn. When I find something that works, I stick with it. But that completely changed my whole, view of the idea of curing lights. I would not use a gun style now, just from the fact of when you're trying to cure, you need to get where you need to go. The other thing is that if you've got a patient that can't open very far and you have one of those standard light guides, it's going to have to be tipped a little bit to accommodate, like I said. And if that happens, then you may end up with part of the light guide where you want it, but then the other part of the light guide is going to tip away. And so you end up with a good cure on the mesial portion, but then we're back to the candy composite thing on the distal portion, because the light guide, instead of being flat on the tooth, is like that. Mm-hmm. And so you end up with a really good cure over here, but where this gap is, this distance, you don't get a good cure, but you think you do.
Right. Dr. Hakim suggests that it's also perfect for pedo patients.
Yeah.
I see that Dr. Ron Kaminer has joined us.
Oh, no.
Hi, Dr. Kaminer.
Hey,
I
Ron.
recorded a podcast with him many years ago that's still available on our podcast on iTunes about, I believe it was on xylitol. Correct me if I'm wrong, Dr. Kaminer. It was a long time ago. But welcome, and thank you for joining us. We don't seem to have any more questions besides that, so I want to thank you for being our guest today.
You're welcome. Thank you.
Thank all of you for joining us live. And I want to let you know that Dr. Flucke is here with us because he's joining us for the Ultradent Summit this weekend. The Ultradent Summit is a fantastic and inspirational event. We have great speakers from all over the world, actually, who come and speak about different disciplines in dentistry. And we just have a great time. We treat you like gold. But since you're not here, that probably means you're not coming tomorrow morning. And we want to share a little with you. So Saturday morning, 8 a.m. Mountain Time, convert it for wherever you are. We're going to broadcast one of the lectures live, and it will be from Dr. Renato Leonardo from Brazil, and he will be discussing ultrasonification, which I've heard him do before, and it's pretty fantastic. So
it is really,
you were there
cool.
in Park City.
I was.
So Dr. Flucke's seen it as well. So make sure to tune in on Saturday morning. We have posted the event on our Facebook page, so you can set a reminder, and it will even, within the reminder, convert a little alert for your time zone. So be sure to join us. If you have questions, or if you're watching this after the fact and didn't get to ask your questions live, please feel free to type them into the comments box, and we will continue to follow up with you. And I've even seen Dr. Flucke pop on after the fact sometimes and answer questions. So we'll see. We'll see. But for sure, someone will answer your questions. And again, thank you so much for joining us live today. It's always a pleasure to be with you.
Thank you guys very much. I appreciate you spending just a little bit of your time with us and learning a little bit more about the science behind curing.